So, what are the goals of oxygen therapy? We are starting the first ASCII question of the day. What are the goals of oxygen therapy?
Correct. Hypoxia.
Correct. Hypoxemia. Very good. That is a major thing that we are worried about.
Reduce work of breathing, sir.
Reduce the work of breathing. Excellent.
To
Right.
increase
So,
the oxygen
hypoxia,
supply and decrease the demands.
decrease myocardial workload. These are the three important things. Treat hypoxia, decrease work of breathing, decrease myocardial workload. Okay, because myocardium has to work more if your patient is hypoxic. So you are decreasing that. And respiratory system has to work more to deliver more oxygen. So these two systems will be affected. That is the reason why oxygen therapy helps in decreasing these two. What factors determine the selection of oxygen delivery systems?
The respiratory rate of the patient.
Consciousness of the patient.
Consciousness, sir.
Already Shukla has told that. Consciousness, respiratory rate, okay, patient comfort and acceptance. Okay, patients should be. Some patients are very frightened about even the face mask, isn't it? You would have seen. Don't keep that. I feel suffocated. And then FiO2 needed. FiO2, depending upon the hypoxia of the patient. Then the least resistant. The system that you deliver should have no resistance at all. And whether there is a need for humidification or not, whether you want to deliver humidified oxygen or not. Otherwise, it's going to be economical and efficient. Okay, these are all the system-based factors, not on the patient price. So when you say the factors determining selection, it is the only thing you are worried about patient comfort. All other needs are depending upon the degree of hypoxemia, the resistance offered, humidification, and economy. Okay, so that is the factor that you are worried about. Then how are oxygen delivery systems classified?
Low flow system and high flow systems.
Very good. Low flow or variable performance patient dependent system, or high flow
and fixed performance device.
Patient independent system. Okay, very good. What are the types of low flow system you know? Or the commonly used systems
Nasal
which are called low
cannulas.
flow. Nasal cannula, excellent.
Oxygen
Nasal
That is
face mask.
it can be classified into three categories. I am giving you the first clue. It is called no capacity, nasal cannula, nasal catheter. What could be the other two? It's called a no capacity cannula. There is no reservoir, nothing. Patient, the continuous flow is there, and patient has to breathe from that.
Partial reservoir breathing
small
system.
capacity.
Yes.
Called small capacity, which is a nasal mask or a simple face mask. Then there is a high capacity, which is partial rebreathing mask or a non-rebreathing mask. So types of low flow system are classified into no capacity, small capacity, and high capacity. And examples are given there. What percent of FiO2 will be delivered with 5 liters of oxygen flow with the nasal cannula?
36%, 40%,
30 to 40%.
Every 1 liter increase will increase from normal 21% to 40% is the answer. Okay. What is this apparatus seen here?
Nasal masks.
nebulizing chair.
This is a mask portion. There is some bottle here, then there is a tube here. What do you call that? There. It's called the aerosol mask. Okay. And deliver from 21% to 100% oxygen and requires a flow rate of 8 to 15 liters. So the minimum flow you require for this aerosol mask is 8 liters, and the maximum you can use is 15 liters. It delivers humidified oxygen to the patient. We put clear distilled water here, it will deliver humidified oxygen to the patient, or you can use bronchodilators also for this. Okay, so that is the idea of this. How was the name dexmedetomidine coined? Any other compound named in the same way? Why dexmedetomidine is called dexmedetomidine? Dextroisomer of medetomidine was found to be an active compound. So this name was coined using the dex in the dextro. So all of you know that all chemicals have a dextro form and a levo form.
Sir.
Okay. So the dextro form or a dextroisomer of medetomidine was the active compound. So if they took the dex from that and added to medetomidine, it became dexmedetomidine. Any other compound which we are very, very frequently using in our day-to-day practice got the name like this?
Hexamethasone, sir.
Levobupivacaine, sir.
Ibuprofen.
There should be this dex in that.
Dexamethasone.
Dexamethasone also I can agree. The methasone is not the original compound. So dextrose is a dextroisomer of glucose. Okay. So the name dextrose was given because it is the dextroisomer of glucose. Right. What is the chemical name for dexmedetomidine? This sometimes they may ask you because this drug is very, very commonly used nowadays. And if they give you the ampule or vial in your hand, they may ask you all that. Of course, it's very difficult to remember, but this is the formula: 4,1,2,3-dimethyl phenyl ethyl PH imidazole. So it is an imidazole compound. At least remember that. What other imidazole compound we are using?
Etomidate, sir.
Etomidate is an induction agent. Very good. So this is also an imidazole compound. What is its mechanism of action? This, of course, is a very common pharmacology question that we should be.
Alpha 2 agonist.
Alpha 2 agonist. Okay. It's highly selective,
Inhibits the
potent
opening
alpha 2
of
agonist. Huh?
inhibits the opening of the voltage gated calcium channels.
The main thing, of course, it's a highly selective, potent alpha 2 agonist with alpha 2 to alpha 1 affinity ratio of 1600 to 1. What is the affinity of clonidine, the earlier version of alpha 2 agonist?
2200:1, sir.
So you mean clonidine is much more powerful?
16 is to 1.
Or it is lesser than this?
300, 16 is to 1.
Yes. 220:1, sir. Sorry, sir.
220. That is this. That is why this has become the second generation, more specific. Name the subtypes of alpha 2 receptors and their action. Are there any subtypes of
2A, 2B, sir.
2A,
very
2B,
good.
2C.
Okay. What are their actions? Where does 2A act, 2B act, 2C act?
2B in brain, sir.
2A in
CNS.
peripheral tissues, sir.
Subtype A, CNS action responsible for sedative, analgesic, and sympatholytic effect. B, peripheral vessels, short-term hypertensive response. It causes a vasoconstriction for a brief period. And subtype C is anxiolytic, mainly anxiolytic. Okay, so these are the three subtypes and their actions. Why should dexmed be avoided in microsurgical procedures?
Causes hypotension.
Hypotension. More than that, any specific reason? It causes hypotension in all patients. Of course, you require a normal pressure for microsurgery. But the specific reason is it causes vasoconstriction in denervated arteries. Okay, so when they cut the small vessels for anastomosis in a pre-flap, that denervated vessel goes into vasoconstriction. So dexmedetomidine is better avoided in microsurgery. Is it possible to reverse the effect of dexmedetomidine? Is there any antidote? Suppose
Uh,
if you
Yes, sir.
Amipazole, sir.
Epinephrine.
Amipazole.
atipamezole is the name, which is an alpha-2 antagonist. We were giving alpha-2 agonist. Dexmedetomidine is an alpha-2 agonist, but atipamezole is an alpha-2 antagonist, which can reverse the effect of dexmed, including the analgesic effect. Okay. Now interpret the following blood gas. pH is 7.12, PaCO2 40, bicarb 16, sodium 140, chloride 100.
Metabolic acidosis with high anion gap.
High anion gap metabolic acidosis.
Fantastic, very good. pH is 7.35, therefore patient is acidemic. Bicarb is low, therefore it is metabolic acidosis is the primary process. Expected PaCO2 compensation should be 32, but here it is 40. So does it have any importance? So the PaCO2 is higher than the expected.
Acidosis.
So there is a secondary respiratory acidosis also. That is the point that you should know. Of course, it's high anion gap. So therefore, it is a high anion gap metabolic acidosis with respiratory acidosis. Even though PaCO2 value looks normal in this case, it should be interpreted with the compensation that should have happened. Okay, please don't forget that point whenever you get a ABG report like this. Now the second problem. pH, PaCO2 again normal, bicarb 22, sodium 135, chloride 110.
High anion gap metabolic acidosis with appropriate respiratory compensation.
High anion gap metabolic acidosis. So how is high anion? Sodium is 135, bicarb plus chloride is
Sorry, sir.
132. Only 3.
Normal
So
anion gap metabolic.
Normal anion gap.
normal or low? Normal is 12 to 16, isn't it? Gap.
Yes, sir.
This is only 3 here. Then how can it be normal? So pH is less 7.3, so it is acidemic. PaCO2 is not elevated, therefore metabolic acidosis is the primary process. Expected PaCO2 compensation is 41. Here it is 40. Anion gap is only 3. So it is a low anion gap metabolic acidosis. So what are the causes of low anion gap? When will you have a low anion gap like this?
Vomiting, sir.
Common causes include decreased unmeasured anions like albumin, increased unmeasured cations, that is calcium, magnesium, lithium, or it can be a lab error. Okay. So remember these 3 points for low anion gap: low albumin, or high calcium, magnesium, and lithium, or it can be a lab error. According to ASA 2008 recommendations, which of the following machine checks should be completed before each case? Number 1, test scavenging system function. Verify that there are no leaks in the gas supply lines between the flow meter and the common gas outlet. Verify the patient suction is adequate to clear the airway. Calibrate the oxygen monitor and check the low oxygen alarm.
Verify the patient suction is adequate to clear the airway.
Yes, every case, first thing you check is suction. That is the recommendation of the ASA 2008 recommendation. Okay. What is this you are seeing here? First one, can you identify what is being shown here?
No.
Exhausted soda.
Capnograph is there, CO2 expired inspired 11, everything values are all given. So this is a capnograph tracing which is shown. Now, which of the following explains the monitor reading seen here? I am giving you the options: incompetent inspiratory valve, incompetent expiratory valve, incompetent pop-off valve, leaking circuit air leak, exhausted CO2 absorbent, more than one of the above causes, more than two of the above causes, none of the above. Which one you have to choose?
C, more than one of
B
the above.
and D, sir.
Very good. So what are the more than one of the above?
Incompetent pop-off valve and bleed and exhausted CO2.
Exhausted carbon dioxide. Fantastic. Right. The capnograph portion of the monitor shows that the patient's carbon dioxide is above 0 millimeters even after expiration. And the way this happens is when the carbon dioxide absorbent is exhausted. So CO2 also elevated when there is an incompetent expiratory valve. So the correct answer is more than one of the above. Very good. Which of the following medical gases is matched incorrectly with the standard color of its canister? 1. Air yellow, B. Oxygen green, 3. Carbon dioxide orange, 4. Nitrous oxide blue, 5. Nitrogen black.
Air
Which
yellow, wrong,
Green.
sir. Air is black, sir.
air is black in our country, but this is international. But if you see that
Yellow is-
oxygen is green,
Oxygen white, sir.
so these are all international color coding. Don't confuse it with our local color coding. International color coding for air is yellow, oxygen green cylinders, nitrous oxide blue, nitrogen black, and carbon dioxide. Have you ever seen a carbon dioxide cylinder in any of your training with hospitals?
Gray color. Gray.
Gray color. Okay, so it is written orange here. Which cylinder will have orange?
Cyclopropane.
Excellent. Cyclopropane, one of the very ancient anesthetic agent, has to come in an orange color. Now, a surgeon is closing from a laparotomy for a small bowel obstruction. The hospital central supply suddenly stops working. There is a size C oxygen cylinder which opens out automatically, but the pressure gauge says 550 psi. And if the patient requires 4 liters by nasal cannula, how long will the canister last? How do you calculate this? The time a partially filled oxygen cylinder, how long it can supply? Which law is employed here?
P1 V1 is equal to P2 V2.
What is the law you use for this? Gas law. Boyle's law. Very good. You have to
Boyle's law.
use Boyle's law. And how do you calculate that? What is the pressure of a full cylinder? PSI.
1800. 1800 to 2000.
2200.
200.
Normally it is 2200. Now it is roughly how much?
550.
550 means what is the proportion out of 2200?
1/4, sir.
1/4, 25%. So the volume also will be only 1/4 of the total capacity. So if you know the total capacity, how many liters of oxygen will be there in a full cylinder?
680 to
600.
700.
The answers are 36 minutes, 42 minutes, 58 minutes, 67, it's more than 75 minutes. At least make a guess.
42 minutes.
Excellent. Your guess is right. A full-size E-oxygen cylinder contains 680 liters of oxygen at 220 psi. As it is stored as a gas, the pressure decreases proportionately as the volume is released. So the pressure here is 550, which is 25% of the original. So the volume must also be 25% of the starting value. So you divide 680 by 4, which is roughly 170 liters in canister. So 170, if you use 4 liters per minute, it will come only for 42.5 minutes. Okay, so the 42 is the correct answer. Excellent. A healthy 25-year-old male is in sitting position for an open craniotomy under general anesthesia when his EtCO2 and heart rate suddenly drop significantly. Rank the following from the most sensitive to the least in diagnosing this patient's problem. Will you
First
take
is
increase in
answer.
heart rate?
Looks like
Huh?
a venous air embolism.
Yeah, that is the diagnosis. But what is the
3.
Transesophageal echo, sir.
Anesophageal echo
No, no,
followed
you
by
must
precordial.
rank. Please read the question properly. There are 5 things that are given, which are being taken as monitoring things that are being going on. One is the heart rate, second is the CEP, third is a transesophageal echo, fourth is a precordial Doppler, 5 is a EtCO2. These 5 parameters are being monitored. Now, which one will be the most sensitive and which one will be the least sensitive? That you have to make them in an order. That is the question. Rank the following from most sensitive to least in diagnosing. Of course, the diagnosis is air embolism. Which one which one will you rely first?
3,
3,
4,
sir.
5.
3,
3, 4, 5, 1, 2, sir.
1, 2.
very good. So 3, 4, 2.
215.
3 is transesophageal, 2, 3, 4 is precordial, and 2 is decreased CVP, 1 is heart rate, and last will be EtCO2. Because why EtCO2 is the last? Even in cardiac arrest, you will have a drop in EtCO2. Okay, so that is, even though earlier it was considered as one of the important things, now it is not considered. I mean, these are the options. Sorry, these are the options, and of course, 3, 4, 5, and 2, 1 are the answers. What is the end product of a reaction of soda lime with carbon
Calcium
dioxide?
carbonate.
Hmm.
With
Calcium hydroxide and
These are all the options: calcium carbonate and water. The choice. The presence of a bubble in the tubing between transducer and an arterial catheter has got the following things: no significance, leads to an artificially high reading, leads to a damping of the tracing, has the greatest effect on the mean blood pressure, has a greater effect on the greatest effect and greater effect on the mean blood pressure. These are the option 4 and 5.
leads to dampening of the
Dampening
tracing.
of
Very
tracing,
good.
sir.
That is very good. In arterial work, by using the fluid column to transfer subtle differences in pressure from patient circulation to transducer, bubbles, even small bubbles, can interrupt the transferring of these waves and result in the damping of the tracing. So answer C is the correct answer. So both systolic and diastolic blood pressure also will be affected. A radial artery line is zeroed to the transducer level to a position of 12 centimeter posterior to the patient's sternal border. While positioning the patient, the arm of the arterial line is elevated and the catheter rests 10 centimeter above the transducer. The blood pressure currently is showing 130 by 72. Which of the following is the actual blood pressure? A 118 by 60, 2 130 by 72 as correctly given there. C 142 by 84, 4 142 by 72, and 5 130 by 82.
E option, sir. 142 by 84.
So you mean to say it will increase?
Yes, sir.
B, sir, 137.
It was 0 12 centimeter below posterior to the patient. Now it is elevated 10 centimeter.
There will be a fall in the BP.
A, sir. A.
Ah,
118/260.
Answer.
when the catheter is elevated, in this case, fluid column forms that push on the transducer and create a higher value than is actually present in the patient. So this value is higher when the arm is elevated. You agree that or not? Because that fluid column is now at a higher level. So the correct answer is first one. You have to reduce this 12 centimeter from this value So it becomes 118 by 60. So you cut down 12 from both systolic as well as diastolic. And the correct answer is first A. ICU patients who are receiving TPN need frequent blood tests to evaluate for which of the following: serum magnesium, phosphate, and calcium, blood culture for infection, liver enzymes and coagulation profile, serum cardiac markers and glucose levels, and
Liver enzymes and coagulation
Yeah.
profile.
because that is the one which will arrange faster. Okay. And the choice is A, done in patients with arrhythmias. Choice B is done with patients who have infection. And choice D is done in patients with heart disorder. So the regular thing is only enzymes and coagulation. Now comes an interesting question. Mr. X had a permanent dual chamber pacemaker implanted. Okay. The following strip was recorded in the cardiothoracic ICU. It revealed A, normal sinus rhythm, B, left bundle branch block, C, P-wave tracking pacing or DDT pacing, ventricular demand or DVA pacing mode, and sorry, only 4 things are there. So which one is the correct answer?
C, sir. It is dual pacing.
Dual pacing. So the question here is a dual chamber, and you have this. It's a this is the spike due to the pacing spike, and followed by a QRS. So it is a P-wave tracking pacing, PPD, that is dual chamber placement sensing and responding. So P-wave tracking pacing in PPD responding mode. IV sedation required for ventilated patients can have which of the following hemodynamic effects? IV sedation required for ventilated patients can have which of the following hemodynamic effects? Increase in blood pressure, increase in respiratory rate, increase in heart rate, decrease blood pressure.
Mostly decrease in blood pressure.
E, sir. Decrease.
Why?
Heart rate, sir.
Increase the heart rate, sir.
Correct answer is decrease, because both ventilation decreases the the venous return because of the change of the intrathoracic pressure from negative to positive. Okay, and on top of that, if you give sedation, it decreases the sympathetic drive. So both will cause a decrease in blood pressure. Your ventilated patient is coughing, red-faced, and seems to be in distress. Which of the following interventions will be most helpful? Reassure the patient that he is okay. Administer midazolam 2 milligram IV. Suction the patient. Lower the head of the bed.
Administer midazolam 2
Suction.
milligram.
Suction the patient, sir.
Suction the patients.
Eh?
Suction the patient.
Suction the patient.
What do you do in ICU? Whenever the patient coughs and you find any secretions in the tube, you always disconnect and try to suction the patient. Correct answer is suction the patient. This is a very common thing which we see every day in ICU. So don't think of the other confusing answers. Think of the common things, you are commonly right. Which of the following is a major concern with synchronized intermittent mandatory ventilation and intermittent ventilation? This can result in hyperventilation, require sedation or paralysis or both, may increase the work of breathing, and decrease cardiac output.
Can result in hyperventilation.
Increase the
the
work of breathing.
Increase the work of breathing.
Increase the work of
Here
breathing.
patient has now, when do you do this same way when the patient regains spontaneous ventilation, isn't it?
Breathing,
So
yes.
if it is not correctly assisted, then it may increase the work of breathing. So that is the correct answer. Which of the following ventilator alarms can happen when the patient stops spontaneously breathing on their own? High respiratory rate, high inspiratory pressure, low exhale tidal volumes, high pressure limit.
Low exhale tidal.
C, sir.
Very
High
easy.
pressure.
Oh, it is patient stops breathing. So there will be no exhaled flow, isn't it?
Yes, sir. Yes, sir.
That is the first thing to happen. Then only pressure will build up and all that thing.
Sir, in that previous question, that ventilated patient coughing,
Hmm.
he's already intubated and on tube. How does he know he has secretions and why does he cough?
The common question is the problem is always whenever you intubate the patient and patient is conscious, it triggers more secretions, constantly, because it is an irritation to the tube. Unless you sedate the patient or paralyze the patient, a conscious patient will always try to
Cough
get the
out the
tube out.
tube.
So
Okay,
that
sir.
will be the problem. That is why we sedate or paralyze to have a very smooth ventilation.
Yes, sir.
So we have a ECG. A 58-year-old man comes to the emergency department with chest pain, loses consciousness while he is having his initial ECG. There's no pulse and takes an occasional deep breathing. What is going on in this patient?
Polymorphic VT, sir.
VT, sir.
Polymorphic VT.
Our side is D pointer, sir.
MI followed by VT.
Hypokalemia, sine wave and ventricular tachycardia.
All
Our
through
side is
or
D pointers.
see, this is a ECG which is running from
MI
here to
followed by
here.
a VT.
Who said that?
Uh,
First analyze the rate. Rate is initially 100. You see here, it is about almost 3 large squares. So 300 divided by 3 large squares is 100. But later on, the number of squares becomes just 1 between the contractions or the complexes. So rate changes from 100 to 300. Rhythm, initially there is, you can see a QRS regularly, but later on it becomes irregular. And PR and phase wave initially present, then unable to visualize. QRS is initially narrow then wide, and ST T wave initially massive ST elevation. You can see here all the ST elevation, massive elevation, especially V2, 3, and AVF with reciprocal depression in V1 and 1 and AVL.
One and
One has got a ST depression, and the AVL also has got a depression. Then we are not unable to decide that. QT, another thing, unable to assess because of this. So all these things point to what? This ECG initially shows an inferior ST elevation MI because of this elevation in 2 and 3 and AVF. All the three are showing ST elevation. So this is an ST elevation MI which deteriorates into ventricular fibrillation later on. As you are just taking the ECG, it becomes a VFib. The breaths described are agonal breaths. This does not respond to normal respiratory effort, and resuscitation from cardiac arrest with CPR should be started immediately. So this is the answer. So whenever any ECG is given, at least try to make the regular interpretation based on the rate, rhythm, PI wave, PR interval, QRS, STTA. In that orderly fashion, at least write the findings. Even if you are not able to make the correct diagnosis, write the finding, you will get the marks. So make it a habit to go for this routine interpretation rather than just jumping into conclusions. Okay. Now another similar ECG interpretation question. Here again, a 58-year-old smoker presents with tight epigastric pain. He looks sweaty and unwell. One of the nurses show you his routine ECG. What is the diagnosis?
Enteroseptal MI with
Acute pericarditis.
enteroseptal MI with
Just now I told you go for the routine interpretation of rate, rhythm, PR interval, QRS like that. Immediately you are trying to jump into the diagnosis. Is the rate normal?
bradycardia.
Bradycardia.
Bradycardia. Severe bradycardia. What is the rate exactly? If you are able to see these large squares, 1, 2, 3, 4, by
Around
6,
40, 30,
7,
40.
around 40.
45.
Excellent. So 300 divided by 7 is almost about 40. And is there a P wave?
Sinus rhythm,
Sinus rhythm. Okay.
regular,
And what about
narrow QRS,
followed by QRS? What about the chest leads? V2,
ST depression.
ST depression and all.
V1 to V4.
proximal lag.
So rate is about 45, rhythm regular, axis normal, QRS narrow, but there is a dramatic ST depression in V1 to V3. This is acute posterior wall in mind. Okay. Anterior leads is the equivalent of upside down ST elevation. This represents what is going on in the posterior region of the heart. Another clue is the bradycardia seen here, because the vessels supplying the posterior of the heart supply the pacemaker region of SA node. So that is the reason why he has got severe bradycardia. So always bradycardia with a ST depression V1 to V3, consider posterior wall in mind. All other things will have tachycardia. Which of the following statement is correct? Type 1 error occurs when there is a difference that only due to chance and it's mainly due to statistical errors in the study design. Histograms are useful to demonstrate the mode of distribution of data set. Type 2 error can occur when there is a real difference that is not shown statistically. And mean, median, mode are equal in normal distribution.
D, sir. Mean,
B
median,
and
mode are equal in normal distribution.
All are true.
All
sir.
four are not true.
All four. And last, to add to the confusion, a box and whisker plot is usually used to demonstrate normally distributed data.
False, sir.
Correct answer is there is actually it is D. I'm sorry, it is written as what is the answer that is given here? The first one is true. That is, the type 1 error occurs when there is a difference that only chance, that mainly due to statistical error. That is true. Histograms are useful to demonstrate mode of distribution of data set. That is also true. Type 2 error can occur when there is real difference not shown statistically. True. Mean, mode and median are equal in distribution. True. A Boston-Wixer plot is usually to demonstrate normally distributed data is the only false answer in this. All the others are true, correct. Which of the following is correct? Standard error of mean is a measure of spread. Number needed to treat is the reciprocal of, I'm sorry, the answer is, what is the standard error of mean? Is a measure of spread. Is it correct or false? Already I have shown you the answer if you are being careful. Because this is not correct either. The answer for this is false. Number needed to treat is the reciprocal of relative risk reduction. Is it true or false?
True.
False again.
False.
The standard error of mean decreases the sample size as the sample size increases.
True, sir.
True. Yes. With much larger sample, you have a lesser error of standard error of mean. Absolute risk reduction is the percentage in intervention group minus percentage is control group.
Control minus intervention. It's false.
True. The percentage difference reduction in percentage in intervention group minus the percentage in control group. That is called the absolute risk reduction. Risk is reduced. Okay.
Okay.
Sample size does not affect the confidence intervals. True or false?
True, sir.
False. Sample size larger the sample size, the lesser will be the confidence interval. smaller the sample size, again sample size is very important both for reducing the standard error of mean and producing the confidence interval. Now, what is shown here? What does it depict?
Bar diagram.
Distribution, sir.
Distribution. It's called bar chart, of course. Bar diagram is not the correct word. It's called the bar
Bar
chart
chart.
is shown here. And bar charts are used to compare different classes of data. The x-axis is usually dimensionless. You can see there is no dimension given, and the y-axis represents the frequency of each class. Okay, and each class could represent a single group or be further divided into subgroups. So these are the each bar has been divided into male, female, and then urology is at the side like that. So this is the pictures of a bar chart. What is shown here and what are the advantages of this? The earlier question, there was this is called the
Distribution
histogram.
histogram.
Okay, this is called the histogram. And this is a specialized bar chart to give visual presentation of interval data. Okay, so it gives you the visual representation of the. So it is a quantitative data, and in particular, continuous data are divided into intervals in order to be integrated into frequency tables. So histograms are useful to show the mode of distribution of the data, whether they are evenly distributed or unevenly distributed. And histograms are useful to demonstrate descriptive statistics like mean, mode, and standard deviation. All these are obtained only from histogram, not from the bar chart. Okay, so these are the points. Suppose the statistics question is always tricky if they ask you, so please hearing this should help you supposing you get a case like that. What are the systematic steps to be followed to select appropriate statistical tests for data?
Sample size selection.
What are the systematic steps to be followed to select appropriate statistical tests from the data that you collect? So you are asked mainly about the data. What are the qualities of the data you should have to select what type of statistical test to employ to analyze the data. That is the meaning of this question.
It depends on the
first
type of data, qualitative or quantitative.
Very good. So this chart will help you to identify. First thing is identify whether the data are qualitative or quantitative. Okay. Now can you from this data predict the other answers? I have shown you the picture. Now can you identify the other qualities, I mean the characteristics the data should have by looking at this picture? Can you make a analysis and tell me the answer? First thing we want to see whether it is a qualitative or a quantitative. I have circled that. What is the next one? For quantitative data, you have to see the type of distribution, whether it is normal or non-normal, or parametric or non-parametric. So it is available only for quantitative data. So that is the second step. Now again, you have the other steps. Can you guess the third step?
Type of
Thank
test to be.
This is the, I am showing the, are you able to see my arrow going there?
Number of groups.
Number of
involved.
groups.
Decide how many groups are being compared. 2 groups are more than 2 groups or 3 groups. Okay. The third thing is to decide the number of groups. Then
Corresponding test.
determine whether data is paired or not unpaired. Okay. So qualitative or quantitative first step, normal or non-normal, or parametric or non-parametric, number of groups 2 or more, then paired or unpaired. These are the 4 steps that we have to use. Okay. So how is a study design classified? Give some examples.
Randomized control study, animal studies, experimental studies, interventional
control
study,
cohort.
observational.
The first classification.
Observational or experimental?
Experimental, excellent. That is the first classification. Study falls into 2 broad categories. One is observational, second is experimental, also called as interventional or treatment group. So observational studies only is classified further into cross-section study, cohort studies, or case control studies. Okay. Whereas experimental studies, you go always for an intervention. There is no subdivision in that. So remember the basic first 2 classification, observational, experimental. Under observation, you have the cohort, case study, or other 3 divisions. What are the benefits of mindfulness therapy in chronic pain management? Have you heard of this word? This has come in the latest Indian Journal of Anesthesia. Of the articles has come. So sometimes examiners coming from north may be very fond of asking something from the latest journal, recent advances. So I thought I will include this in case you have the habit of going through the journals. Okay.
Overdosage can be avoided.
This includes, this is a mindfulness practice. It integrates, this is a topic under which particular, this is chronic pain management. It is given here. Okay. So mindfulness is something like a meditation therapy. So this integrates the emotion, reduces anxiety, relieves chronic pain, calms the body, decreases stress, improves sleep. Okay. So all these things are achieved by this mindfulness therapy. And so it also causes what is called negative stress cycle. So the patients enter into a cycle of automatic thoughts about stress or pain, which leads to negative moods and emotions, ultimately resulting in maladaptive behaviors, which often end up sustaining the cycle by worsening their symptoms. So this has been found as one of the important reasons for patients with chronic pain. Previously, we used to say that they go into a state of depression and not able to come out and always complaining about the pain. But now they have analyzed that and found out why it is happening. So a cycle of automatic thoughts which lead to negative moods and emotions. So this is the picture of negative stress cycle. There is a stress which causes automatic thoughts, creates negative moods, then maladaptive behavior, negative physical symptoms, and it becomes a vicious cycle. So our mindfulness therapy is now trying to break this cycle and bring the patient out of that. For that, you must first block these automatic thoughts. That will be achieved by integrating emotions, reduce anxiety, relief of chronic pain, calms the body. All these things have been achieved. So what is the basis of mindfulness based intervention? The short form of MBA is mindfulness based intervention. What is the basis? Of course, unless you have read the article, I don't expect the answer from you. The greatest impact of mindfulness is it is causing what is called neural plasticity in the brain. So this mindfulness based intervention is causing neural plasticity in the brain. The brain regions most consistently altered with MRI are, these are all the areas. It acts on the insula, sensory cortex, anterior cingulate cortex, prefrontal cortex, hippocampus, amygdala. And in all these things, it increases the activation and increases sometimes the volume and their function. It causes body awareness, self-awareness, and so changes. All these changes are caused by acting on these various parts of the central nervous system. So this article is there in the latest IJA So those of you who are interested can go through that. Oxygen pressure sensor shut-off valve requires what oxygen pressure to remain open and allow nitrous oxide to flow into a nitrous oxide rotameter. This is one of the hypoxic prevention safety measures in the anesthesia machine. So we have an oxygen pressure sensor shut-off valve which will automatically close the nitrous oxide flow also. So what is the pressure required? So A answer 10 psi, 25 psi,
25.
B
25
100.
psi.
Correct. Correct answer is 25 psi. The second stage oxygen pressure regulator delivers a constant oxygen pressure to the rotameter at answer 4 psi, 8 psi, 16 psi, 32 psi, and 64 psi.
16 psi.
16 psi.
Excellent. Correct answer is 16 psi. Halothane vaporizer will deliver an acute concentration of an unknown volatile anesthetic if the latter shares which property with halothane. The properties are molecular weight, viscosity, vapor pressure, blood gas
Pressure.
partition coefficient.
Vapor pressure.
Vapor
Vapor
pressure, sir.
pressure. Answer is vapor pressure. Very good. So 3 easy questions. All of you answered correctly. Which of the following rotameter flow indicators is read in the middle of the dial? Bobbin, H float, ball float, skirted float, and non-rotating float.
Skirted float.
Ball floats.
Ball float is the
Middle
correct
ball
answer.
float.
When the pressure gauge on a compressed gas cylinder containing nitrous oxide begins to fall from its previous constant pressure of 750 psi, how many liters of gas remain in the cylinder? The options are 200, 400, 600, 800, cannot be calculated.
Cannot be
200.
calculated.
Cannot be calculated. Is the correct answer?
200.
100, 200, 600. The
Up to
pressure
25%.
gauge on size E compressed gas cylinder containing nitrous oxide shows 750 psi when it is full and will continue to register 750 psi until approximately 3/4 of the gas has left the cylinder. Okay, so a full cylinder nitrous oxide contains 1600 liters. Therefore, when 400 liters of gas remains in the cylinder, the pressure within the cylinder will begin to fall and gradually come to zero. Okay, so it is not that the earlier thinking that until the last drop is present, it will show 750 and suddenly drop. It doesn't happen. All of you would have noticed, those who are using cylinder, it will, when it starts falling, it gradually falls and comes to zero within a short time. That depends on what is the flow rate that you are using. But when it starts to fall, there is still 400 liters of gas remaining in the cylinder. Okay, so the correct answer is B. A mechanical ventilator is said to deliver a tidal volume of 500 ml at the rate of 6 breaths per minute and an inspiratory to expiratory ratio of 1:2. The fresh gas flow into the breathing circuit is 6 liters per minute. In a patient with normal total pulmonary compliance, the actual tidal volume delivered will be the following: 600 ml, 700 ml, 800 ml, 900 ml, 1000 ml. Sir. You have set the tidal volume only at 500 ml, but the fresh gas flow into the breathing circuit is 6 liters per minute. The IE ratio is 1:2. Will it deliver the set tidal volume of 500 or it will be more? Nowadays, in the new anesthesia workstations, we have a mechanism to deliver only the 500 that we set, not anything extra. And what is that mechanism called? Any idea?
1000, sir.
Question passed. Okay,
1000.
because the ventilator pressure relief valve is closed during inspiration, both the gas from the ventilator bellows and fresh gas flow will be delivered to the patient's breathing circuit. In this question, the IE ratio is 1:2. So 2 liters per minute, that is 1/3 of the fresh gas flow in inspiration phase. So every breath, 2 liters divided by 330 ml will be augmented to tidal volume. So 500 plus 330 will be roughly 800 ml. So the correct answer is C. So nowadays, all the machines, we are trying to avoid this excess gas going to the patient by a mechanism called decoupling of fresh gas flow, which will deliver only this set 500 ml from the bellows, and the fresh gas flow will go and occupy the bellows before that, and it will not add this extra from the fresh gas flow. That is called decoupling of the fresh gas flow. Okay,
Yes, sir.
shall we stop? It's almost 8 o'clock. I have some more questions, but we'll keep it for next week. Or you want me to complete? No
Students,
answers.
I think they are tired, sir.
Tired. So yeah, mind is not working.
Yes, sir.
I'll close that then.
Okay, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Any doubts from the students?